Here we have interesting case of metastatic adenocarcinoma. The story of this patient, I received this case from a colleague working in a different hospital for female 44 years old. Patient scanned in the first week of November, shows multiple areas of consolidation with electron seen in the left upper lobe, right middle lobe, and left lower lobe, complaining of shortness of breathing. Let's see the case again. Here we have left upper lobe pneumonia, and there are coexisting central nodules of soft tissue density, again seen in the right upper and middle lobes. Some of them are confluent into larger areas of consolidation, but still there is central nodules coexisting or adjacent to the areas of consolidation. And here, as you can see, central nodules start to be enlarged to form larger consolidation. So we have distribution of nodules in the centrilobular location. So this is a sign of either endobronchial infection or tumor. But we have another nodules of different distribution seen along the pleural surface, as you can see here along the fissures. These pleural nodules along the fissures and along the costal margin indicate presence of another type of distribution of nodules. Beside the centrilobular distribution, there is randomly distributed nodules. This is the clue for diagnosing of adenocarcinoma metastatic. This is the first scan. Patient was complaining of cough, fever, and shortness of breathing. In this scenario, patient is treated as infectious pneumonia. As you see here, the consolidation, adjacent centrilobular nodules, and here some of them are branching into tree-in-bud appearance. Also, this can happen in both infection or tumor. And this is the mode of distribution. This is the mode of spread is endobronchial spread for tumor or infection. With this complaint or this clinical information, so infectious pneumonia is likely, according to the clinical practice usual scenario. Patient was unresolved, or also patient has progression in the scan we showed before. So here we can think about the adenocarcinoma as the underlying pathology, and it's not an infection. The nodules that can happen in infection or tumor, we can have endobronchial spread. We have tumor or infection, presence of the nodules in the centrilobular location. They are not present along the fissure or the pleural surface, as you can see here. In case of lymphangitis carcinomatosis, there is perilymphatic spread of the nodules to be seen along the bronchovascular bundle, subpleural location, along the fissures, and the pleural surface, interlobular septa as well. But in our case, we have these two modes of distribution. We have the centrilobular nodules, and we have the randomly distributed nodules, which are the nodules detected along the pleural surface and along the fissure. So this combination means this patient has primary in the lung and metastasized into the same lungs. Here I took screenshot for the images from the second scan in November to show you the locations for the randomly distributed nodules, as you can see here in the right lung apex, here right middle lobe, along the fissure here, as you notice, there is consolidation right middle lobe here, and we have a pleural nodule along the fissure in the opposite direction, in the right lower lobe. Here again we have pleural nodules. This is the clue for diagnosing metastatic adenocarcinoma. We have here nodules along the fissure, along the pleural surface. As you can see here, they are significant in amount, plus the presence of the centrilobular nodules So we have two modes of distribution, one of them for the primary and the second one for the metastasis, hematogenous spread of tumor. Again, these are the pleural surface located nodules due to metastasis. So in invasive mucinous adenocarcinoma, which is formerly called bronchoalveolar carcinoma, it's a variant of invasive adenocarcinoma. It's predominantly invasive, although it shows lipidic pattern of growth. It's commonly multicentric, multilobar, and bilateral, as in this case. This reflects the bronchogenic dissemination, which is the endobronchial spread. They are peripherally located, and there is predilection for the lower lobe in general, but in our case, it started in the left upper lobe. It has a strong tendency for spread in the lung, to metastasize into lung, as in this case. But as we noted as well, there was no lymphadenopathy, and which is typical for mucinous adenocarcinoma, much less common spread into the lymph nodes compared to the other subtypes of adenocarcinoma. What we can see in HRCT, pneumonia-like, when you recognize pneumonia-like, either localized or diffuse, as in the start of this case, and in the second scan, it was diffused. The consolidation itself, it shows air bronchogram, but this air bronchogram is abnormal. The air bronchogram could be stretched or irregular, as dilated or rigid or narrowed. There could be air bubbles or lucences, coexisting ground glass beside the consolidation. Within the consolidation itself, we can see areas of low density or CT angiogram sign. Beside the pneumonia, it can cause bulging of the interlobular fissure, but this is not specific also. It can happen in Staphylococcus aureus or Klebsiella as well, infection. There could be coexisting centrilobular nodules, solid or subsolid nodule, means soft tissue with halo of ground glass density. As in our case, we have the coexisting centrilobular nodules of soft tissue density. Also, may be randomly distributed. This is a clue for diagnosing of invasive adenocarcinoma from the beginning. So could be, this case could be the diagnosed adenocarcinoma from the beginning. Actually, yes, we have some features to suggest adenocarcinoma, but practical wise, this is not the situation which we encounter. Patient always treated as infectious pneumonia. What are the findings here that could suggest adenocarcinoma in this initial scan? The CT angiogram, as you can see here, but it's not a specific sign, plus the attenuation. See the air bronchogram? Looks like they are attenuated and stretched out. This also a clue. Major fissure is bulging. Here we have nodules along the fissure, indicating Grandin nodules. Beside or aside from the centrilobular nodules of soft tissue density, we have here nodules along the fissure. This should highlight the presence of metastasis from the start, from the initial scan. See the nodule here. It's obvious the nodule is resting on the fissure. So it is a possibility. But in clinical practice, this is not happening. I want to show you also here the tree in bud, which can happen in either infection or tumor because of endobronchial spread of infection or tumor cells. As I said, this could be highlighted in the report of radiologist. That patient shows features suggest invasive mucinous adenocarcinoma or can be formulated in a different way. They have a case of left upper lobe pneumonia, however, invasive mucinous adenocarcinoma to be ruled out. But in clinical practice, what is happening is that patient is treated by antibiotics, and when it is unresolved, it can progress or persist. At that time, clinicians start to consider bronchoalveolar carcinoma, or the new name, invasive mucinous adenocarcinoma. And I am done with the case. Thanks for your attention.